we're going to talk about COVID-19. If you thought this was a different topic, you're in the wrong Zoom chat. What else is there to talk about these days? As an epidemiologist, this is all I've been asked to talk about 24/7 for the last 2 months. It's consumed my life. So let's begin with this. There's something called the IDEA model. This stands for the incidence decay and exponential adjustment model. It doesn't matter what it is. It's one of the best models we have for charting the progress of this disease. It's put together by a U of T epidemiologist named David Fisman, who is one of the best in the world at this. And what we're looking at here is Ontario, the projected trajectory of the disease. Okay. And those points are the actual cases. They seem to be falling along the projected curve, which is great. And the bottom curve is the cumulative number of cases. So it was predicted that by the end of the first wave, we would top out at just over 20,000 cases, which is where we are now. And we should be flattening out our curve at a bare minimum. Now, you probably notice at the end, we have some upticks. That's because of the nonsense that's been happening these past couple of weeks with the early opening. So that's a bit concerning. Prior to this, everything was following as planned with the declining cases. Let's look at Ottawa. Ottawa is much better, right? So Ottawa is following the same plan, but we are not seeing uptick of cases, and we're maxing out at about 2,000 total cases in this city. So we're looking pretty good there. If you look at Kingston, Kingston's looking fantastic. So Kingston hasn't had a new case in several days, and before that, their previous case was a couple weeks before them. So the disease is almost gone in Kingston. What we can take away from this is what we're seeing across the entire country, which is this isn't just one epidemic, this is many epidemics with different profiles, different characteristics in different parts of the country and different parts of the province. Right now, the Canadian epidemic is essentially an Ontario and Quebec epidemic. That's it. These are the two provinces driving everything. And in Ontario, it's essentially a Toronto and Peel epidemic. Those two counties, are driving most of the cases. So that's a bit suggestive about, how we should panic, if we should panic at all, maybe some of the strategies for opening up. And I know that the Premier is thinking about more regional approaches throughout the province to respond to the caseload locally. If this is entirely a Toronto situation, then maybe Kingston doesn't have to have the same rigid amounts of control. We can talk about that. There's some pros and cons to that way of thinking. So in the US, they have a similar kind of situation. Their modeling uses something called the IHME. I forget what that stands for. But they predicted early on that someone's microphone is still on there. I'm hearing some feedback. They predicted early on that 97% of the cases of this first wave would be done by the end of June. And we still think that's going to be the case. So North America should see the subsiding of the first wave by the end of June, unless something really stupid happens, like people start going to the beach in large numbers and stop socially distancing. But otherwise, we're on trend to have this first wave under control within the next month or so. So this is how the IHME model looks for the US. You can see here that there are three different lines. The dotted brownish line is what we think the infectious rate is in the USA, and that solid brown line is the actual cases that we know about, and that solid blue line is the testing that's been done. So they're also on trend to have most of this done by the start of July, if all goes well, if all goes well. Okay, so we can look at some possible timelines for resolution. Some people think, well, in 1 or 2 months, this all goes away. It's possible, but everything we know about epidemics like this says it's not going to happen that way. Everything we know about historical pandemics says that these things come in multiple waves for a number of reasons. And this is just the first wave, hopefully the worst wave, maybe not, right? So if this goes away in 1 or 2 months and never comes back, it means we got everything wrong, or the virus mutated into nothingness, which is always possible. In fact, we think that the Spanish flu went away because it just mutated and stopped being lethal. So we can always hold out hope for that. It's possible that this mostly gets under control in 3 to 4 months, But that requires a fair amount of public health leadership and compliance by the population. This is possible. I'm hopeful that we can do this and live our new normal. We can talk about that later on. 4 to 12 months is possible. It means we have this normally summer and this powerful second wave in the fall. And this is what we want to kind of avoid. Even though most of us are planning for a second wave in the fall, like we're closing universities in the fall so that, you know, in preparation for having to go back inside. And maybe this goes away in 2 or 3 years because we didn't do anything. And we have to, and a lot of suffering happens as a result. So these are some of the ballpark figures, how this might work. Some people have theorized that this goes away in the summer. There's no evidence or reasons to suggest this. There is some slight evidence to show that with every increase in temperature, the transmission decreases a little bit. With every increase in humidity, the transmission decreases a little bit as well. And the more time we spend outdoors, the less likely we are confined inside and infecting each other. So those are all good things. And the way it works like this, the disease is transmitted via droplets that come out of my lungs and land on someone's face and infects their mucous membranes. And we think those droplets can travel about 2 meters, which is why we have that 6 foot 2 meter rule. In higher humidity and higher temperature, it doesn't go as far. It goes maybe 1.5 meters. And that's enough at the population level to diminish transmission substantially, maybe. So that might be why some of the hotter countries are having just a little bit better time. But it will not cause the virus to go away entirely. And remember MERS, that's the Middle Eastern Respiratory Syndrome, which was a coronavirus as well. That was raging through the hot desert of the Middle East, and temperature had no effect on that. So there is no reason to expect it to go away. The common cold goes away in summer, often because of temperature and humidity, and comes back again in the fall. So don't bank on the summer to take care of it, but we'll probably see some diminishing of transmission. What do we need to know? So the things that we care about right now, we don't know the true prevalence of the disease in our society. Prevalence is how many people currently have it. There's something called seroprevalence, which is how many people have had it. So how many people have that marker in their bloodstream. Some studies are underway around the world. You know, New York has a seroprevalence of about 14.9%, we think. Stockholm thinks they're like 7%. The best estimates for Canada are about 5% at the high end. So that's not good news when it comes to seeking herd immunity. But we're going to start doing large-scale seroprevalence studies very soon because we have the antibody test now. So we don't really know yet what the true CFR is. CFR is the case fatality rate. That's the fraction of cases that results in death. Okay, the fraction of known cases. That's important because we only know about the cases that we test for. And if we're not doing enough testing, then we don't really have an accurate sense of the true lethality of the disease. So the case fatality rate is, again, the fraction of known cases that die. There's something called the infection fatality rate, which is the portion of all cases that die. And the infection fatality rate is what we ultimately want. And to do that, we need to have an accurate estimate of the prevalence. But that's going deep into the mathematical woods. These are the things that we're working on. We don't really know the risk factors for hospitalization thoroughly yet. The data is coming in fast. We used to think it was just older people. It's not true. We used to think it was just, you know, asthmatics and people with immunocompromised systems. That's not true. It could be obesity. It could be diabetes, hypertension, any number of things. So this is a weird disease. It's not following a lot of the trends that we've seen before in other respiratory diseases. So it's tempting to think of it as a really bad flu. That would be a mistake. The only thing it has in common with the flu is the way it's spread and the way it manifests early on as a cough. That's about it. So the serology test is what everybody cares about. That's the antibody test. And Canada has just okayed our very first antibody test. There are dozens of them on the open market. I don't recommend people seek the non-licensed ones because they have a lot of imprecision and they create a lot of chaos in our data. But the serology test will tell us how many people have had the disease. That gives us a sense of the true prevalence. And that allows us to guess what the true fatality rate is. And that allows us also to guess what the true morbidity rate is and things like that. It also tells us maybe a little bit about immunity. So we don't yet know for certain that recovery gives you immunity. It probably does. Okay, and most people agree now that it probably does give you some immunity. We don't know yet how much you need to be immune, because not everybody produces the same amount of antibodies. Not everyone has as robust an immune response. Some people have a tepid kind of immune response. And we don't know how long that immunity lasts for. It could be days, weeks, months, it could be a lifetime. What we know from the common cold, you're immune for a few weeks. The flu, maybe a few months before it mutates. So there's some hope that this will give immunity for at least a few months, but we don't know. So that's why it's important that I believe people should not actively seek infection for the purposes of getting immunity, because it may not be possible, and infection comes with it a lot of pain. There are horror stories of people struggling to recover months later. There's some long-term disability issues, lung fibrosis, kidney damage, heart disease that come with this disease. So it's not advisable to seek out infection. Okay, other things that might be important. You probably heard some mention of the BCG vaccine. That's the tuberculosis vaccine. And some people who were born in other countries probably had it. And countries with the BCG vaccine seem to have a lesser transmission rate. And that got people thinking that maybe this vaccine is providing some protection for a lot of people. And it's not surprising, because the BCG vaccine has been shown in other capacities to provide protection for other diseases. So it's been investigated as possibly a way to attenuate or slow down transmission in people like healthcare workers or maybe the elderly. It's not clear yet. And of course, we all know about the emerging treatments, chloroquine, and President Trump talks about that a lot. Zinc is being used widely in hospitals. Interferon, the Cubans were big on interferon for a while. Remdesivir, you probably heard of. The company that makes remdesivir, their stock price skyrocketed, and I was going to buy their shares, and I dragged my feet on it months ago, and I wish I had. But remdesivir is showing the first clinical evidence of a drug that lessens mortality for this disease. That's a positive thing. We finally have a tool that's been proven to work. It's not a big effect, but it's an effect. Convalescent plasma is when we take an infected person and we spin down their plasma because it has all the antibodies, we presume, and just inject that plasma into another sick person and hope that does the job. This is an ancient technique. It was used during the plague, not the plague, it was used during the Spanish flu and some other infections. It has a lot of downsides, like sometimes you're giving people other infections or antibodies that aren't specific to this disease, and that causes some inflammation problems and maybe some kidney disease and lung issues. So it has some dangers. It's being heavily investigated though, and the Red Cross and the Canada Blood Services are actively collecting blood from recovered COVID patients for this purpose. And monoclonal antibodies. So that's a synthetic antibody that you make in the lab from mice usually. And this is really intriguing, and I'm very bullish on the power of monoclonal antibodies to provide us with the treatment. It's important to know that we'll talk about vaccines in a second, but the vaccine is probably 2 years away. You've heard that before, if ever. We're going to have powerful treatments well before a vaccine comes. Very powerful treatments. We're already seeing remdesivir. The monoclonal antibodies, in my opinion, have the best chance of an outright cure, if not a powerful treatment. And you heard this rumors in the U of T, a man named Dr. Sidhu, I think, who claims to have a cure. You know, distrust science by press release, but the science that he's expressing makes sense. So he has extracted or synthesized an antibody from his mouse population that seems to either prevent this virus from entering your cell or mitigates the symptoms caused once it does enter your cell. And the power of this is, if it works, we can mass produce this really easily and get it out quickly. So that's why I'm bullish on this technology. So you probably heard about people who disagree with the seriousness of this disease. I call them contrarians, and there's a handful of fairly outspoken ones. I'm a scientist, which means I try to listen to everybody, but I follow the best evidence at the end of the day. So some of the the arguments that this is not as bad as we think and we should not have a lockdown in the first place is that the IFR is low. Remember, the IFR is the infection fatality rate. That's the proportion of actual cases that die. So their argument is that it's actually on par with, if not lower than, the flu. So, and the reason they say this is that more people are infected than we know about. Well, duh, that's a given. But they're saying that so many more people are infected and so many are asymptomatic that, in fact, the proportion that end up dying is actually quite small. Every sign, every actual data point that we have so far points to that not being true. Every study that's been done suggests that the infection fatality rate is about 1%, maybe a little bit less. That doesn't sound like a high number. That's a very high number for an infectious disease. The flu has an infection fatality rate of about 0.12%. This one so far in Spain or Italy is about 1.2%. In New York, 0.8%. In UK, we think it's 0.6%. In my opinion, when all said and done, it'll probably be between 0.3 and 0.5% of cases die. That's still 3 to 5 times more deadly than the flu. The second thing that the contrarians say is that maybe we're closer to herd immunity than we thought. So herd immunity, again, is when enough people are sick, then when enough people are immune, when enough people are immune, any new infections can't find purchase of who to infect, right? It's like you picture a herd of cattle. They keep the weak ones in the center and the powerful ones outside. So a predator comes in, the people on the inside of the herd never see the predator. It's dealt with by the strong ones of the periphery. So those of us who are immune deal with the pathogen, and those who aren't immune never encounter it. That's why vaccines usually work. We don't need everybody to be vaccinated. We just need the majority to be vaccinated. We can compute what percentage of the population needs to be vaccinated to get herd immunity. For this disease, we think it's between 40 and 70% need to be immune. All evidence so far points to 5% of Canada, if not less, has been exposed. Right? So we're very far away from herd immunity. New York, as I mentioned, is about 15%, which is probably the highest in the world. Spain is probably close. So they're all far from herd immunity. And another more rational argument, it has to do with how people mix. So a lot of the models assume that I have an equal probability of encountering everybody in the country. It's not true, obviously, right? It's unlikely that I'll meet anybody on this call, right, in real life. So we call that homogeneous mixing. But when mixing is heterogeneous, it's less likely to spread, right? Because I'm not seeing everybody else. So some people claim that because of this, we should not see the high peaks that we expected. That makes a bit of sense. However, if it's true, it also means we will never get to herd immunity, naturally, because people can't spread the disease fast enough. Also, New York and Italy are such incredible hotspots that it seems that you don't really need homogeneous mixing. This is such an incredibly infectious disease. It's unbelievably infectious that it seems to be doing quite well without everyone having to contact everybody else. Let's talk about the vaccine. So everybody wants to know about the vaccine, how far away it is. The world record for vaccine development from conceptualization to mass production and distribution is about 4 years. We think if we pulled all the stops, we can get this out in 18 months, assuming what we have right now works. So there are at least 6 types of vaccines. And this is all good news, by the way, because 17 years ago with SARS, we didn't have the technology we have today. We didn't know about a variety of vaccine technologies. All we knew was, here's the virus, I'm going to give it to you, and maybe you'll mount a response, or here's a fragment of the virus, I'm going to give it to you, or here's a weakened virus, I'll give it to you. But now we have at least 6 types. The first is a live virus, where we actually, inject you with 1 or 2 or a handful of virus organisms, and hopefully you mount a response without getting too sick. The second is what we call an attenuated virus. That's when we give you a virus that's been weakened. It's not strong enough to actually kill you or make you really sick, but it's strong enough to have your body have target practice on it. So you produce a lot of antibodies and get immune that way. The third is a relatively new technique, and that is a nucleic acid vaccine. That uses just the genetic fragment of the RNA of this vaccine. And this virus is an RNA virus. It's not a DNA virus, which makes it even more dangerous. RNA viruses are a pain in the the new vaccines are looking at these fragments. So the company Moderna, they're trialing an RNA vaccine, and they have some good results so far. Sometimes we have subunit vaccines that we don't inject you with the DNA or the virus. We take a fragment of the protein on the outside of the virus and inject you with that. And your body recognizes that, hey, I know that, that's that evil virus. And they ramp up their antibody production very, very safely. We have a viral vector vaccine. That's when we use another virus that's relatively safe, because viruses are all around us all the time. And viruses are really good at getting into your cells. They're essentially a bit of genetic content with an outboard motor. They're a torpedo directed into your DNA. So we use one of these torpedoes to deliver the virus safely in an attenuated fashion, so that we need a lesser dose of this evil virus that's going to be packaged above, around, or inside of a safer virus, and that will allow you to mount the immune response. And then we have the repurposing of existing vaccines. I mentioned the BCG vaccine. There may be some other vaccines that are possible to jig a little bit, and the advantage there is they've already been tested for safety. So if they end up working, we can go right to manufacturing and distribution. So AstraZeneca, you probably heard of, has a really good live virus vaccine. They're the ones trialing in Oxford, England, and it's looking so good already that they've already gone right to manufacturing, with the assumption that this is going to work so well, we're going to skip the whole ramp up the factory thing. We're going to have millions of doses ready to go the second those clinical trials come back positive. So there's a lot of hope there. In fact, the USA has committed $2 billion to secure 300 million doses of this vaccine when it's ready. So the rate limiting step for vaccines, there's a scientific rate limiting step. You know, it takes time to develop and test. Then there's the administrative rate limiting step. It takes time to work through the testing, the safety testing, the efficacy testing, the manufacturing, the distribution, all that stuff. So we're doing everything we can to lower those administrative barriers so that only the science needs to get done. And this graph here shows us the number of vaccines being developed around the world. It's crazy. There are scores of vaccines competing around the world to be manufactured for this disease. And I like to think that the private sector is our secret weapon in 2020. Governments alone could never do this, but we have hundreds of companies independently committing their resources to creating this life-saving endeavor. As you can see, most are looking at the protein-based, the fragment on the outside of the virus, but the ones that seem to be most promising are the live virus ones and the nucleic acid ones. Okay, let's talk about how this is transmitted. There are 6 different ways that viruses in general are transmitted. The first is by droplets. So if I'm infected, my body is producing more viruses. That's the virus's goal, by the way. I mentioned it's a bit of genetic material with an outboard motor, a torpedo. It's trying to torpedo into your cells to reprogram your DNA to make more copies of it. It's devious that way. In fact, the human genome actually contains a lot of virus DNA going back millions of years. We've been reprogrammed by viruses for generations. So it's trying to reprogram us. And when it does that, we mount an immune response that creates mucus and coughing. But in that coughing and mucus are more of the virus that we have created now, because our DNA is now cranking out more viruses. So we cough it up, and in that cough comes these chunks of fluid, big droplets, like several microns wide, containing more virus. And they land on somebody else's face, their eyes, their mouth, their nose, gets absorbed into the mucous membrane, and they become infected. Aerosol is when the nuclei of those droplets, the bit of virus inside, ends up floating in the air. If you look a quiet Sunday morning and you see bits of particles floating in your living room air, that's aerosol. Those are things floating around. So aerosol transmission is when the virus alights on those tiny particles and they stay afloat longer and are a bit more insidious. Fomite transmission is when you cough on a doorknob and someone else touches that doorknob and they touch their face and they become infected that way. So we call the doorknob a fomite. It's an object that is intermediary. Body fluids are obvious, sexual contact, that sort of thing. Vectors are when like an animal, a mosquito will bite an infectious person, then bite somebody else and give it that way. And the fecal oral route is self-explanatory. Please don't make me explain it. I think you understand what that means. So for this virus, we know that it's definitely droplet transmitted, no question. It's probably a little bit aerosol transmitted as well. It might be theoretically fomite transmitted, which is why we wipe down our groceries and wash our hands a lot and try to avoid touching doorknobs, that sort of thing. There's no actual evidence that anyone's ever got it from touching an object, but it's theoretically possible. It's been shown in the laboratory that it's possible, so we keep it as an option that we try to minimize. Body fluid transmission, no evidence that it's ever happened. However, it's possible because we have detected this virus in saliva. So it's possible if you kiss somebody, maybe you can get it that way. But I'm skeptical because saliva doesn't end up in a mucous membrane unless someone spits in your eye or something like that. But it's possible. Zero evidence that it is a vector delivered, and I would be very surprised if a mosquito bite could give it to you. Very surprised. The fecal oral route is possible because we have found viral shedding in feces of infected people, and that's because the kinds of cells that this virus likes to invade are these smooth muscle cells you find in your esophagus, your nasal palate, and also in your gut. And so for a lot of people, it can infect their intestinal cells. And as a result, it ends up in feces. So again, I don't know of any case of anyone ever gotten it from feces, but it's theoretically possible. But we should focus on the droplets. That's everything. If we can control the droplet transmission, the rest is cake. So we'll get to some of the questions now. And I will send a question about herd immunity or let the virus burn itself. Did our government make the right choice, especially given the huge impact on the economy? I mean, that's a values judgment. I don't really know the answer to that. Epidemiologically, I think you have to do something. Keep in mind that had we done nothing, all the numbers pointed to a lot of dead Canadians in a short amount of time. The narrative at the time was we want to avoid overwhelming the hospital system. And that's true, we should have avoided it, but we didn't really understand at the time the morbidity, the disability it caused as well. So it's not just dying, it's a lot of suffering. So with that knowledge now, I think, yeah, it was the right thing to do, because if you stay indoors for like 6 weeks, you drive that caseload down to a small trickle. So let me back up for a second. The plan, as best as I understand it, wasn't to flatten the curve. It was to drive the caseload down, then deploy enormous public health infrastructure, like testing and tracing, et cetera, to keep the caseload down. And if we can do that quickly enough, like in 4 weeks of hard suppression, then the economy could open up again and we have minimal impact. We were slow to act, in my opinion. And so as a result, we had a mitigation approach, not a suppression approach, and the economy stayed closed longer than it was supposed to. But whether or not it was the right thing to do, I'm not really qualified to answer that question. I can say that it was a thing to do. And if your goal is to save lives, it was the thing to do. If your goal is to save lives and sustain wealth, maybe not. We'll see what happens to Sweden, because as everybody knows, Sweden took a different path, and we won't know who was right until we get to the finish line. Right now, I will say that according to my reading of the data, Sweden is paying a hefty price in terms of death. And it's not a price that I would have liked to have paid, but you know, everyone, it is a values judgment, and people are going to debate what the right thing to do was. What data becomes available to study the curve and collect numbers of deaths? Can this data be used as build strategies? Okay, yes. Data is everything. As I've been saying in the media for a long time, we're past the point in this pandemic where it's about doctors treating people, epidemiologists making predictions. It's now at the point where as the economy opens up, it's data nerds collecting information to direct our resources. This is critical, which is why we're just obsessed right now with testing and fixing our data pipeline infrastructure. Because if we can't do that, then this thing bubbles in the background, and next thing we know, we're in crisis mode again. So if we want to keep the economy open, we need real-time good data. What kind of data? Incident data, so the number of new cases. Not just the ones we know about, we have to go out and actually hunt down the asymptomatic cases. This is a special disease because it is an asymptomatic pandemic. We haven't seen this in a while, if ever. You know, the flu is not asymptomatic. The Spanish flu was not asymptomatic. Up to maybe anywhere between 40 and 70% of new transmissions are caused by people who have the disease and don't know it. If we just rely on people coming to be tested, we're never going to capture that amount. We have to go out and actively test people who don't have symptoms to get a true sense of who has it. We need to be able to know the IFR versus the CFR. Let me back up. The CFR, again, is the proportion of known cases who die, but we don't know all the cases. If we knew all the cases, we would know the IFR, which is the true proportion of cases that die. When we know that, we know what the actual risk is and how lethal this actually is. We don't know really how many people get like seriously sick. A lot of them do. So we need to understand that better. The affected populations. So for the longest time, people thought this was just an old person's disease. It is not just an old person's disease. In China, that was a narrative coming out. Men over 70 were dying. By the time it got to Spain, we saw it was middle-aged people, smokers. In the USA, it's anything goes, right? So they're a fairly unwell population. Obesity, diabetes, hypertension, drug users, pre-existing conditions. Of course, there's a strong socioeconomic grain through this. Poor people tend to get it more so and suffer more and die more for a number of reasons. So we don't really fully understand that yet. We have no idea how this works amongst children, which is a horrifying realization. Until we know the transmission dynamics amongst children, opening schools is difficult and challenging. And I suspect that much of the asymptomatic spread that's going to happen as the economy opens up will be driven by children, or at least people under 20, young people who otherwise probably don't even know they're sick, and they're just giving it to their parents and grandparents. So we have to understand how this manifests in children. They don't show the same symptoms as adults. R and K. So R is the base reproduction number. You hear this spoken about in the media a fair bit. That is the average number of new cases produced by an old case. So if I'm infected and the R is 2, then I'm going to give it to 2 other people before I either die or recover. And those 2 other people are going to give it to 2 other people each before they die or recover. Right? So we see suddenly blah, 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 it grows fast. If the R is 1, I get to give it to 1 person, then I recover. They give it to 1 person, and they recover. And so it's always 1 person being affected, which is, we can manage that. When the R is less than 1, then we are driving the epidemic into the ground. That's the goal, to keep the R below 1. So a lot of modelers are keeping a daily track of what the R actually is based upon our case numbers. And that will decide when we open more things up if that R is low. So Canada-wide, the R is pretty good. It's less than 1. But Ontario and Quebec are the outliers. K is a dispersion factor. That's, where it is, how many people are getting it in different clusters. Okay, questions. Do we all have to be tested? Okay, so I like to think of it this way. Testing has 3 purposes, 3 lenses: a clinical lens, a public health lens, and a planning lens. So most people think about just the clinical lens. I'm sick, I want to get tested so I know how to treat myself. Or if I'm a doctor, I'm going to test you to figure out what you've got so we know what to do with you. It's a very individualistic way of thinking. This is all about me, which is great. A public health lens is different. We test to figure out who has the disease in order to know what to do with you, whether we have to quarantine you, and how to contact trace you. The planning lens is different. I test you to figure out if I need to shut down this building where you work, if I need to throw resources at this region. So all 3 lenses are important. Just the clinical lens, if you focus on that, as most people do, you miss the nuance of population health control, which is we need data on everybody to figure out how to control this thing. So does everybody have to be tested? Not really. But if you're going to be a high-risk area, like if you work in a nursing home or a school, you probably should get tested and regularly, because you test negative today, you might test positive tomorrow. So we have to have a rolling testing regimen. And we have to have random proactive testing of asymptomatic people. And the way it stops spread is, think of it this way. Let's say economy's open, we're going about our business, and we're doing random spot checking at different parts of the province and I catch a couple of cases of teenagers have it in Kingston, let's say, I descend on them with overwhelming public health powers. I quarantine those teenagers. I contact trace to figure out who they've been in contact with these past 2 weeks. I test them right away a couple of times to make sure. And if any of them test positive, I quarantine them and figure out who they've been in contact with, etc. With that kind of overwhelming power and control, I can prevent those handful of cases from becoming an outbreak and prevent an outbreak from becoming an epidemic. So we're trying to identify embers before they become forest fires. That's why we do proactive testing. Okay? And that's how we keep the economy open, by doing this kind of extreme aggressive testing, which is expensive, but a lot cheaper than having to go back inside for 6 weeks. Virtual life, are we going to see more online tools, et cetera, et cetera, et cetera? Yeah, absolutely. That ain't going anywhere until the internet fails. So we're already on that trend. This just gave us a kick in the pants to continue it. Like as a professor, I'm loving the virtual thesis defenses. I can just roll out of bed, put on my headphones and do a thesis defense. I don't have to show up. So that's going to be a constant new thing. We see Twitter, for example, they've said that from now on, their employees work from home. Even when the pandemic is over, their employees will work from home. The digital divide is the distance between those who have IT access and those who don't. This has accelerated the need to close that gap. So that's a good thing, that's happening. And there might be some new opportunities here. So in universities, I'm pushing for our university to take this seriously. Everyone's going online in the fall. And so we're going to have to compete for students who want a good online education. We can't just do this is good enough. We have to do high quality online education. Bells and whistles, all that stuff. So there we go. I see there's some questions here. I'll get to them when I get through these slides. Lessons learned. What could we have done differently as business owners? It's a tough one. I mean, I'm a business owner as well, and I think about what I could have done. We have to foresee the unforeseeable, unfortunately, but there are people whose job that is. We have to listen to them, public health people, scientists, economists, forecasters. I think it's important to diversify income streams to make yourself resilient against emergencies like this. If it's not a pandemic, it's a natural disaster. It's a solar flare. It's a world war. It's a price hike in oil. All these things could have done similar damage to our businesses and economic health. So how robust are we against these large-scale global actions over which we have no control? I think the best way to be robust is to have a diversified income stream and to be mentally prepared for short-term loss. There are some things that the pandemic accelerated that were already underway. We already had a trend towards artificial intelligence displacing a lot of workers. That's just accelerated because now people can't go to work. We need the AIs to manage it. You probably noticed if you're on Facebook that some of your posts are being flagged as against community standards, even though it's a picture of a cat or something. That's because they've replaced their censors with AI because their censors can't go to work. So that's started already. Working from home, learning from home, all that stuff is accelerated. Food delivery, the lesser intra-city travel. I think when this is over, travel will be back because people need to travel and because travel is a key artery for global commerce, but there'll be lesser of it in certain sectors. For example, my sector as an academic, now that we've discovered it's possible to have online conferences, I think that's going to become a norm. We have to look to other countries more and more. So we did not do that this time around. We could have looked to South Korea, to Taiwan, to China, and taken it more seriously. We had advanced warning of several months, and we, for the most part, squandered that advanced warning. We could have taken that time to acquire the tests. New Zealand did things perfectly. They had some advantages geographically, but they, from day one, they knew exactly what to do because they looked around and saw other countries. And as a result, they are reaping the rewards of early action. We have to invest in surveillance. Surveillance in medical terms means the ability to find new cases, not just for this disease, but for all infectious diseases. And this was a recommendation from SARS 17 years ago. It's a low investment approach. It's a low cost investment. It's setting up systems around the world to detect cases as they appear. And early warning like that could have saved us billions of dollars. And we have to look at history. So what have we learned from pandemics in the past? The Spanish flu is the obvious example here. And remember, the Spanish flu, the first wave was brutal. Then after the first wave was over, people went outside, started partying. And then the second wave was more brutal. People stopped their distancing and suddenly millions died. More people died in those first two waves than were killed in the First World War, I think, at least in North America. So what we learned from that is we got to take this interwave period very seriously. We got a shot right now to prevent a strong second wave. A second wave is going to happen. It doesn't have to be noticeable or strong. So if we do our job right now, we can stay open. We can stay open through the second wave. That's the goal. Okay, given this weekend's events in Toronto, how much are people willing to follow? Yeah, it's a tough one, right? I'm not a sociologist, but I'm struggling with this myself. And as a public health communicator, I think people are missing a lot of the messaging, which is, this isn't necessarily about my personal liberties. This is about my responsibilities to my community to stay open. We got to stay open. And the way we stay open is by just keeping our physical distance and by washing our hands a lot and by wearing a mask when we're in close proximity. If we redefine what it means to socialize, that helps. All these, I hear about single people having online dates now, which is nice. It's not physically satisfying, I understand, but it's something. Focus on hygiene. So we've been lax in keeping our public bathrooms clean. We've been lax in keeping our restaurants as clean as we can. That has to be stepped up. That's going to help a lot. And we've been lax in how we focus on our vulnerable groups, our old people. It's a tragedy how we treated our elderly. The homeless, this disease is rampaging through the homeless population, and mental illness is part of that. So we knew that was going to be a problem. Now we're paying the price. So looking ahead, we can make those changes now and improve those situations to prevent further damage. Okay, the new normal. How is this pandemic will affect our future economic, social, and psychological well-being? I don't know. But I look to other countries, South Korea, Iceland, Taiwan. They've done a good job, and their new normal is social distancing, physical distancing we call it, reliance on the technology, like the tracing apps, and a compliant population that feels that they're part of the process. I understand that every society is different. We are a liberal-minded society that really values individual freedom. And this is a hard sell to us for that reason. But my response is always, do you want to stay open? Do you want your businesses to thrive? Do you want the freedom to go hang out with your friends? If that's the case, do these few things. Allow yourself to be tracked, unfortunately, and we can do that. But there are a lot of reasons for hope. Okay, I mentioned the new therapies. They're coming down fast and hard, and I have a lot of faith in them. And as we know more about transmission dynamics, we know that walking by somebody on the street isn't going to give you the disease. It's just an intense, intimate conversation, probably will. So that's size for hope. So let me turn off the stop share, and I'll check out the chat. See what's going on here. Okay, ooh, a lot of questions. Ooh. Okay, does that mean the decision made by Premier Ford last week to allow everyone to be tested was the right one? Okay, he didn't really, he said that, but that's not really what he is doing. What he's doing is loosening the criteria for testing. Because right now you get tested only if you satisfy a certain number of symptoms. He's just saying that you don't need that many symptoms anymore, but you do need a reason to suspect that you have it. Even if that means I know somebody who had it and they were in my house the other day. That's good enough. And that's a good thing. We need to, here's how I describe it. Imagine the virus is a cockroach in a dark room. Okay, we want to catch that cockroach. We want to stamp the life out of it. Hey, I'm a vegetarian. I love all living things. I want to kill this virus so bad. So, and I picture our testing strategy is a flashlight in the dark room. So if we put the flashlight down and wait for it, the cockroach to walk by, maybe you'll get lucky and see it. Okay, that's what we're doing now. We're waiting for the cases to come to us. We're waiting for symptomatic people to present themselves to the flashlight. The breadth of the beam of the flashlight is the rigor of the criteria. So the more criteria we give for testing, the tighter the beam is. The fewer criteria, the wider the beam is. So the fewer criteria, we're going to have a larger space to catch that cockroach. That's good. That's a good thing. It's not ideal, though. The ideal is we take that wide beam and we move it around the room and get that cockroach. So that's the active surveillance. That's the proactive testing. That's our best bet. And if we have multiple flashlights, oh, we're going to get that guy for sure. Right? So, so Ford's decision is a good thing, but it's not ideal. We need more. Next question. How can we tell how many people were infected if we have a good percentage of patients who are either asymptomatic or never tested with mild symptoms? Yeah, we don't know yet because we haven't got the serology test. Again, one has been licensed in Canada and it's going to be deployed soon. I'm not sure how it's going to be deployed, probably first through research projects, but I think very soon a family doctor can probably prescribe it. So that's how we do it, seroprevalence studies. And again, several from around the world are happening already, and they're very intriguing. In Canada, we need to have our own thorough national seroprevalence study, and that'll tell us a lot, including how far we are along to herd immunity. And by the way, we are not far along at all. We need about like 40 to 70%. We're probably about 5%. That 5% comes from some modeling. Ipsos Reid did a study, or Angus Reid, I was confused them, did a study of trying to guess the number of households that are impacted in Canada based upon how they're reporting symptoms. And they suggest that the true prevalence is about 14 times higher than what we think. So currently, the actual measured cases is between like 1% and 2%. So they're saying it's like maybe it's 20%, which would be fantastic if it is. It means that we're closer to the herd immunity, but you know, I'm skeptical. How can we tell how many people were infected? Oh, I got that one. In your opinion, what is the likelihood of a second wave this fall? How likely is it going to be worse than a current wave? I would say a second wave is guaranteed, but what isn't guaranteed is, will we notice it? It may be so small that it doesn't even make the news. And the way we get it to be unnoticeable is by doing all the proper public health things. So this past weekend, this past week, you heard all the news about the uptick in cases in Ontario that are due almost directly to the Mother's Day long weekend of people being outside. That was a small thing. People went outside and socialized a bit more than they needed to, and that resulted in a climb again of the curve. That's crazy that that small amount of activity had that much of an effect on our curve. So that tells us that we need to be really serious about the distancing as the economy opens up to prevent that curve from going up again. That's the second wave, that curve going up again. If we do everything right, if everyone follows the rules, and if we have really good contact tracing and really good testing that's frequently done, then I'm an optimist. I think we can avoid that second wave being really disruptive to our lives. But there's a reason that universities have decided the fall is online, because there isn't a lot of faith that people can do this. Since antibody testing is not specific due to potential clearing infection through the cell-mediated immunity, since antibody testing is not specific due to potential clearing infection through cell-mediated immunity, and some of the patient vanishes after a few weeks, I don't see a question there, it's a statement. Antibody testing is not specific. Some of the problems with antibody testing is a very high false positive rate. That might have to do with it's sensitive to the antibodies produced by other coronaviruses, like the common cold. And so that's why there's so many bad antibody tests out there. It's not hard to make an antibody test. It's hard to make a good one. And so there are literally scores of antibody tests being tested by Health Canada right now. So yeah, I'm not an expert on the microbiology here, so I can't really answer that well, except to say that the sensitivity and specificity of the antibody test is always an issue. In one of my slides, you mentioned that we might be in this for the next 12 to 18 months. If so, what do you recommend we do with the economy, as I don't think many sectors will survive? Okay, so I'm not an economist. I will say that if I'm being asked my opinion, as I am, I think several sectors need to diversify and to find some creativity, unfortunately. Some things have to reopen, even under the risk. Airline travel has to reopen to some extent. We need goods and services to flow. Education has to reopen to some extent. We can't keep kids indoors. I mean, there comes a time when the public health threat of a depressed economy exceeds the public health damage of a raging disease. Right? We're almost there, in my opinion. There comes a time when the damage done to children not being in school exceeds the risk of those children getting sick, right? I think we're almost there. So some things are going to open whether we like it or not, because there's nothing else we can do about it. What we have to do is figure out public health investments to keep them safe while it happens. Think about schools. We can spend the money and hire a boatload of teachers to have smaller classrooms, have classrooms of fewer than 10 kids. We can do that. It's physically possible. It just takes political will and resources, right? We can make gyms have plexiglass barriers between all the workout things. We can have independent workout rooms in gyms. It's really expensive, but it's possible. It's physically possible. So we need some creativity, and we need the willingness to make some upfront investments to keep some sectors open. In order to keep the economy open, I think we need a national mass testing program, risk adjusted, but on average once a week. Yeah. Do you agree it's viable to ramp up mass testing? Yeah, absolutely. Mass testing is critical, and frequent mass testing, in addition to frequent random mass testing. The questioner has asked about point-of-care rapid testing kits. The US is trying that already. They're trying out these do-it-yourself-at-home testing kits. You order them online, you swab yourself, and you send them into a central lab, and you get your results back. We can do that. Absolutely. We should have mobile testing kits as well. India has excellent mobile testing kits. A van drives around, and people stop and get swabbed, and they move on. Korea has, they're famous for the drive-through testing kits. And if you test positive, you get a text right away saying, you tested positive, go home and lock yourself indoors. Right? You have to have faith that people will comply. But absolutely, we have to do that. How can we tell how many have had the disease? We can tell that through the antibody test, in theory, if it's a good test. Keep in mind, the antibody test tells us if you've been exposed to the virus and if you've mounted an immune response. It's possible you mounted an immune response but weren't infected. It's possible you mounted an immune response but are not immune if your response is tepid. So we don't know how much of the immune response confers immunity. We don't know how long it lasts, and we don't know which antibodies are specific for immunity. So these things have to be worked out still. What is the risk for the health of our children? Okay. One of the great data gaps is that we don't really understand the epidemiology of transmission and clinical manifestation amongst children well. They haven't been studied as well as they can be or should be. And one of the reasons for that is that the population size of infected children is not as great. But we're seeing already things like Kawasaki syndrome, COVID toes, strange aches, strange coagulations affecting children. One of the reasons that children don't manifest symptoms is their immune systems aren't as advanced, and so they don't overwhelm their own bodies with these cytokines, as we call them. Whereas we old folks, we have such advanced immune systems. They go crazy when they see this new virus, and suddenly we're drowning in our own fluids because our body is just trying to kill the intruder so much. So the risk for the health of the children in general, the risk is poor, meaning that children in general don't get sick as much, which is a blessing. Some do though. Some have died and some have gotten quite ill, just not at the same proportion as adults. The risk for children though at the population level is that children are vectors for the disease. They can bring it home and give it to an immunocompromised person or an old person, etc. So, there is I have no clear answer to that, but that is a priority for research. The Germans are kind of at the forefront right now. They produced a study a couple of weeks ago showing that the transmission rate amongst children is quite high, which was very saddening to see because we're all kind of hoping that children not only would not get sick as much, but maybe they wouldn't transmit it as much. And that would solve a lot of problems for us. Send them back to school and they're fine, they won't bring it home. It's not so much anymore. It sounds very negative of me, and that's the last question, by the way, so keep asking more if you have any more. I sound very negative, but I'm not negative. I'm actually an optimist about this because I see the exceptional work being done by our biosciences industry. I'm quite sanguine about the new monoclonal antibody work, which I think will lead to very powerful treatments very soon. So one of the reasons I don't like the Swedish approach, which says, let's infect a lot of people now and hope for herd immunity. One of the reasons I don't like it is that people are dying now, absolutely. People are dying now who maybe wouldn't die a year from now because there are better therapies a year from now. There are better therapies a month from now. There are better therapies now than we had a month ago. A month ago, we didn't even know what the ventilator settings were for this disease. Now we know, better how to use them. So if you got the disease 2 months ago, you had a much higher chance of dying than getting it now. So the longer we delay infection, the higher chances you will survive infection, due simply to the advancement in medical science that's happening at a breakneck speed. So that's why I'm an optimist. I think that by the time, I just had a newborn child, right? And my child will not see his elderly grandparents for months. I think by the time he does meet his grandparents, we will have so many tools in our chest that I won't be as afraid to expose them as I am now. So that's my optimistic statement. What that means for businesses is that as people develop more confidence, the economy can open up better. Let me say something about confidence again. People are forgetting that this isn't about individual risk, it's about population risk. So the risk to us as individuals has always been incredibly low, incredibly low. Over 90% of people who get this disease, is that right? Yeah, over 90% of people get this disease will be fine, okay? Most will have what we call mild symptoms, which aren't mild at all, they're actually kind of brutal, but you'll survive it. A number will have some disability issues for a few months, which is not great, but you'll survive it. The problem is when we scale this up at a population level, it takes an enormous toll on people. So if you've got like a 0.1% chance of dying, I'll roll the dice and take that chance. That's better than most surgical interventions, right? But if 1,000 people roll the dice, then you've got, what's that, 10 people dying. Is that right? I can't do math all of a sudden. One person dying. Jeez, okay. And if 10,000, that's 10 people, and so forth. So by the time we're at several million people, we have tens of thousands, hundreds of thousands of people dying. That's why this is dangerous. So what I tell people who are afraid to go outside is your probability of something bad happening to you is the product of three things. First is the product of the probability of you encountering an infected person. Multiply that by the probability of you actually getting the disease from that infected person. Multiply that by the probability of you getting really sick from that infection. So the probability of you getting really sick from the infection is due to your individual circumstances, your resilience, your age, your pre-existing conditions. The probability of you getting infected by that person is the result of the extent of your interaction. Was it a pass-by? Was it a conversation? Were you making out in the backseat of a car? Whatever. But the probability of you encountering a sick person is entirely due to the incident rate in the community. If we keep the incident rate down, that first number gets really small. And you multiply it by two other small numbers, that probability is vanishingly small. So as individuals, when we go out into the community, we should not be afraid of our fellow citizen, especially if we are observing like the mask wearing and the distancing, because those things affect that second number, your probability of getting it from somebody. So even if you end up bumping into Typhoid Mary in the park, who's really, really sick and infectious, and you've kept your distance and Typhoid Mary is wearing the mask, you're probably fine. So I'll say it again, this has never been about individual risk and fear. It's about population scalable risk and fear, which brings me to the masks. One of the reasons I advocate for mask wearing is masks are not about me protecting myself, it's me protecting you and you protecting me. Even the crappiest homemade cloth mask prevents me from spewing droplets more than a couple of centimeters beyond my mouth. Now, as an individual, maybe it doesn't change my life all that much. Maybe it doesn't change my individual risk all that much. But if 10,000 people are wearing masks, suddenly that transmission rate gets really slow indeed. And the burden of cases in the community gets really low. And suddenly that first number gets really low. And that reduces everyone's risk and increases our safety. This is a community partnership endeavor. Everyone's got a role to play. So it's not rocket science. It's epidemiology, essentially. I tell my students, it's dividing two numbers. That's all it is. And the trick is figuring out which two numbers to divide and what it means. So it's a very simple way of thinking. Everyone just does their part, and we can get through this just fine. But what I'm not seeing is everyone is doing their part. We look at the weekend partiers. And I see that I don't have a lot of faith right now in my fellow citizens to do the right thing. But if we do, our economies can be fine, in my opinion. Here you go, more questions here. Why do some healthy people get really sick and some not at all? It's a good question. It's a really good question, and we don't really know. There's some theories. There's some pre-existing responses. There's a couple of interesting studies out of China suggesting that blood type has a role to play. I think blood type A, if I remember correctly, is most likely to get sick. Don't quote me on that, have to look it up. It's a small study, it may not be reproducible, but it's interesting. But a lot of people are thinking now that there may be some genetic circumstances that predispose us to being sick. And there may be some micronutrient deficiencies. So we are seeing some success in vitamin C megadosing and vitamin D megadosing, but that seems to be only the case amongst people who are already deficient in those things. So if you just, if you make sure you've got your sufficient dosage, then that deficiency won't manifest as a vulnerability. How do you get herd immunity if we, well, the question is, how do we get herd immunity if we have these non-pharmaceutical interventions like distancing? What is the goal? Herd immunity? I think the goal is herd immunity artificially through a vaccine. If you want natural herd immunity, that's brutal. Think about New York. So New York is 15% seroprevalence. They're about halfway, a third of the way, probably a third of the way to herd immunity. They went through hell to get there. They'd have to go through hell 2 more times. They lost, what, 20,000 people in New York? They have to lose another 20,000 with complete chaos to get herd immunity that way. Maybe you want that. I don't want that. So, and don't forget that natural infection confers some immunity, we think, but it comes at a horrible personal price, disability, suffering, and so forth. And the ways in which people are dying are just horrible. People die without being able to say goodbye to their loved ones. Spouses in different rooms dying and not knowing about it because they can't communicate. It's a tragic, tragic disease. So herd immunity through natural infection, in my opinion, is an amoral path. You can disagree, that's fine. But herd immunity through a vaccine is far preferable. We can titrate and calibrate a vaccine to elicit an appropriate immune response with very few side effects. That's the way we have to do it, we may come to the point where it's not possible. And when that happens, then maybe we throw the doors open and do a Sweden. Keep in mind though, Sweden is not laissez-faire. Sweden has physical distancing. Sweden has results on restrictions on how many people can gather. You can't stand at a bar in Sweden. There are limits in domestic travel. So Sweden is not the liberal bastion people are pointing it out to be. The big difference is they had no stay-at-home lockdown, and they have no law enforcement for their restrictions. Right? But they are distancing as well. And they're paying a hefty price, by the way. The next question, which vaccine stocks would you buy? Good question. So I was looking at Gilead, Moderna, and AstraZeneca. I'm not a financial advisor, but those are the ones I was looking at. So Moderna makes the remdesivir. I'm confused. So one of them makes the RNA vaccine. One of them makes the antiviral remdesivir, and one of them makes the live virus vaccine. So AstraZeneca makes the live virus vaccine. Gilead makes remdesivir, and Moderna makes the RNA vaccine. So keep abreast. I mean, I was going to buy stock in those things, and I lost. Maybe I did. I'm not telling you. Maybe I did. I stupidly bought a lot of stock in cruise lines because I saw, hey, they're tanking. They're going to go up in a couple of years. Let's buy them out now. Foolish me. I thought they'd be up to speed in a couple months. So I lost a fair bit of money there. So don't take any investment advice from me. More questions. I keep on talking, more questions. Well, I mean, it's a challenging thing, right? And I am very concerned for people's wherewithal, and we can't lose sight of the fact that public health includes economic suffering, and public health includes mental health, and public health includes children needing to go to school. All this is part of it. And we can't just be solely focused on one infectious disease. And I will say though that this is a warm-up for a truly horrible pandemic, which is we're overdue for in about 15, 20 years maybe. So imagine if this disease had a fatality rate that's more than 1%, if it was like 2, 5, 10%, oh my goodness. Imagine if it was aerosol driven right away, oh my goodness. So we got a little bit lucky in some ways that we get to test out our pandemic preparedness in something that is weirdly manageable. Next question, would you bring back kids sports in the fall? Ooh, kids sports. Man, that's a tough one. Depends on the sport. Non-contact sport maybe, like a racket sport. Contact sports, ooh. Like I'm a big martial arts fan, a big jiu-jitsu, judo, and wrestling guy. And it hurts me that we can't do these things right now. But one thing's possible, right? It's possible that maybe by the fall, we'll have so much testing capacity that everyone who goes into school gets tested every single day, maybe. And if you test negative, then you can go about your business and do everything normally. That's the ideal. And right now we can't do that because we don't have the testing capacity and we don't have the rapid on-site tests. So right now, testing, let's go back to the cockroach analogy. So I mentioned we're chasing the virus in a dark room. And we're hoping to catch the cockroach by moving the light around, but we're never going to see the cockroach. We're going to see where the cockroach was 2 weeks ago, which isn't ideal. And the reason for that is two things. The test itself takes a while to get results for it. And second of all, our infrastructure is such that we take a swab, we put it in a cooler, we drive it to a lab where it goes into the queue, and then maybe in a couple of days, the lab tech gets to it, does the analysis, then faxes the results to some lab, literally faxing, 1995 technology, faxing to some central authority, and then maybe you get a result back in 2 weeks. That's ridiculous. But imagine we had rapid on-site tests where you get a result in 15 minutes. South Korea has that capacity, I'm told. I've never seen it in action, but I'm told. The White House claims to have that capacity. There's a company called Abbott Labs. They make a test called IDW Now that has a rapid 15-minute test. So we in Canada have the Spartan Biosciences test, which had a less than 1 hour turnaround, but has some laboratory issues. I'm not sure that test is going to pan out. If we can get rapid on-site tests that don't require driving to a lab, that you dip your finger prick and wait your 10 minutes, oh, you're clean, you can go in, then that changes everything. We can do that every single, we can have bars open if everyone gets in, gets their finger prick and gets tested. Now, the challenge there, of course, is there are going to be some false negatives. And so you need like a really good test, maybe 2 tests before you get in. You need to have a situation, an infrastructure, a plan in place for people who test positive. If you're lining up to get into a bar and you test positive, what now? Does the entire bar get shut down? Does everyone get quarantined? Does public health show up and arrest you? There's stigma issues here to talk about, to think about. Let me turn the light on here. All right, so there are things we haven't thought about yet as the testing unfolds, the infrastructure demands. You've probably seen like grocery stores having temperature checks, like before you get inside. I don't really, that's neither here nor there for me, that's fine. But just because you've got a fever doesn't mean you've got COVID. And because you've got COVID doesn't mean you got a fever. And maybe you got a fever and took some Tylenol and suppressed the fever. It doesn't solve a lot of the problems. And plus, if you do have a fever, what happens then? Do you get arrested? Do you get sent home? Do people point at you and call you Typhoid Mary? I mean, these are things we haven't thought about yet. Yeah, so here, another question here. My expectations are, unless we achieve herd immunity through vaccines or with antiviral treatment, we will be practicing for a very long time. Yeah, but let me read that question again if you can't see it. Your expectations are, unless we achieve herd immunity through vaccines or come up with antiviral treatment, we will be practicing social distancing for a long time. Yeah. So let's dissect that statement. I think we have a very good chance of getting a vaccine. If we don't get a vaccine, I suspect the question is actually probing, do we then let herd immunity happen naturally? If we can't get a vaccine, it probably means we can't get herd immunity naturally either. okay? We don't get herd immunity for the common cold. So these things are kind of related, right? So if it's possible to get herd immunity from natural infection, then it's probable we can get herd immunity from a vaccine. So if we can't get any kind of treatment, what happens then? History has shown us that when all else fails, the disease does go away. It goes away with a brutal path in its wake. The Spanish flu, the sweating sickness of 16th or 15th century England, other various strange epidemics. So it will go away, but it will take an enormous toll on us. And usually they go away because they mutate for some strange reason, or their natural reservoirs get dissolved. But to be more transparent in my answer, I think we probably have social distancing for several months, possibly a couple of years. I have enormous faith in a vaccine, enormous faith. I have even more faith in antiviral treatment. And that faith is not misplaced. It's not based on my innate optimism, even though I am very much an innate optimist. It's from what I see happening in the science. I find it very positive. Next question. How do we answer people with the conspiracy theory when they talk about the Eye of Darkness written by Dean Koontz? Contagion, something going on behind the scenes. Yeah, I mean, I have no insights into whether this is a man-made issue, except to say that Occam's razor suggests that there is no evidence to suggest that this is anything other than a natural phenomenon. We've been expecting this for a while. Let's be blunt about this. So Dean Koontz was not a prophet. He just knew what epidemiologists were saying for decades. I wrote a paper 20 years ago predicting this. I wasn't the only one, several were. Okay, we've been saying this for, in fact, I'm surprised it took this long. And we've been predicting it because of several things. One is our population is so large that we are infringing upon these previously unexplored areas. Ebola came about because somebody went into the Ebola Valley and disturbed a nest of something, bats I think it was, that previously were not disturbed. A lot of these flu-like diseases come out of Asia because of the incredible large population there living in close proximity to domestic animals, particularly pigs and birds. That's why we have swine flu and bird flu. Okay, and what happens is one of those animals gets sick, and then viruses and bacteria share DNA in a very special way, very intimate way. And I say, oh, I want some of that DNA. Give me some of that, right? That allows me entry into that species over there. That's why the flu always comes out of Asia every year. It's so many people live in close proximity to pigs and birds that the viruses is always kind of swapping things out and finding new ways to be infectious. That's my way of saying that this was always going to happen. You don't need a high-tech bio lab to make it. You just needed a wet market with a lot of weird animals living close together. Okay, it doesn't require a conspiracy. Now, if it was man-made, you'd like to think that it would look that whoever made it would have a cure, and if they had a cure, why isn't it being used? I don't know. I don't like talking about conspiracies. I mean, it's a bit nonsensical. However, it's nonsensical until it isn't. So I have no information on this except to say I see no reason to believe that it is. What bothers me more is the movement to deny the seriousness of this, the plandemic stuff, those Bakersfield doctors, and I spent a lot of time writing about responding to those things and showing point by point why they're wrong, and yet I come across the wall of denial of people saying I must be in the pocket of Bill Gates and Big Pharma. Okay, maybe I am. I'd love to be, but the numbers are still clear. I've shown you where your math is wrong. So it's something that I struggle with a lot right now as a public health communicator, and I'm giving a lecture next week at the University of Ottawa on how to do proper public health communication in this crisis, and it's frustrating for me because every day it's trying to be patient with people, showing that there is no evidence to suggest that there's anything untoward going on. There is plenty of evidence to suggest that there is everything natural going on. Is there any current evidence on transmission from animals? Okay, that's a good question. It's pretty clear now that cats can get it, ferrets can get it, primates can get it, like gorillas and monkeys, maybe chimps. Dogs, so far, zero evidence that dogs can get it. And there's zero evidence that any animal can give it to us. At least not through respiration. So it's possible that maybe your neighbor's sick and your neighbor coughs on their dog and you pet the dog and you touch your face. The dog didn't give it to you. Your neighbor gave it to you via the dog's hair. Okay, let's be clear about that. So far it seems that dogs are fine. Cats, like I said, cats can get it, but there's been zero cases of a cat giving it to somebody. And there might have been a case of a primate giving it to somebody, but who's interacting with primates these days? If you got a monkey at home, you probably shouldn't. So I wouldn't worry about the monkey so much there. But a lot of what we know about immunity comes from the monkey studies. So we know that monkeys can definitely get it because we're infecting monkeys deliberately, which offends my vegetarian sensibilities, but we are, and it's, we get the antibody data that way. So I'm not too concerned about getting it from animals. I am concerned about giving it to animals. I don't think any animal has died of it though. So they may be mounting a good immune response. This dying is bad, obviously. I think people are overly focused on the death aspects of this. Definitely the people I talk to on social media, they want to argue about the infection fatality rate and say, it's not that high, we shouldn't be so scared. Okay, maybe it's not that high. It is high, for the record, but let's say it isn't. Why are we obsessed with death? It does other things. It creates enormous amounts of suffering. It creates enormous amounts of lung fibrosis, coagulation issues, long-term disability issues, kidney function issues. It's a bad disease to get. There was a time earlier on where I kind of wanted to get it. I kind of wanted to get it over with and be able to talk about it. But now, oh no, I don't want this thing. We'll see how it goes. I mean, it is mutating as well. All viruses mutate. It doesn't appear to be mutating as quickly as other viruses, though. And so there are a lot of clickbait articles and panic articles about, oh, the virus is mutating, there are 8 strains. My sister sends me an article every day saying, oh my God, it's mutating, get a vaccine. It's okay that it's mutating. The question is, when we get a vaccine, will this vaccine affect all the various mutations? And I liken the example to races. There are different races of humanity, and we all look different. We're different mutations of the same core stock, but the same thing kills us all. A bullet to the brain will kill us all. A vaccine is a bullet to the brain of this virus. Oh, we're at an hour and a half, aren't we? I guess I'll stop talking. I can lecture forever, as you can probably see. I guess I'll stop there unless there are any additional questions. Raham, we have some comments. I do want to say, I think there's going to be a question about, is everybody okay with public sharing of this video? If you are, let me know. If you're not, let me know or let us know. Otherwise, I would like to be able to share it on my YouTube channel. But if you don't want me to, that's fine too. So do either email the organizer or text me.
Yeah, I think what's going to happen, Rachel will be sending the questions an email, and one of the questions will be this, and we're going to collect the information. We will definitely let you know. Thank you very, very much. It was extremely helpful and very informative, of course. And thank you for your time. We really appreciate it.
My pleasure. Thank you so much. I really hope it was useful. That's
it was wonderful. Absolutely.
Love the applause. Thank you so much. Okay, well, I'm gonna log out now then. If you want to keep track of what I do, just go to my website, which is mylastname.com, deonandan.com, and see ya. Log it out. Bye-bye.